Is there an overturned ladder, indicating that the patient may have fallen? Has the patient been to a cold outdoor has the patient been to a cold outdoor environment, been exposed to a cold outdoor environment for a long time? Or is there no apparent mechanism of injury, leading you to presume that the patient has a medical problem rather than trauma or an injury? Although the EMT cannot rely completely on the patient's environment to rule out trauma, when combined with the chief complaint, for example, the patient complaining of symptoms that sound more like a medical problem than an injury, environmental clues become extremely helpful. Scan 12.1, Manual Stabilization of the Head and Neck. You should apply manual stabilization of the head and neck on first contact with any patient you suspect may have an injury to the spine, based on mechanism of injury or history or signs and symptoms. When you apply manual stabilization, your object is to hold the patient's head still in a neutral in-line position. That is, the head should be facing forward and not turned to either side, nor tilted forward nor backwards. You must be careful not to pull or twist the patient's head, but rather to hold it perfectly still and to remind the patient not to try to move it. If your patient is in another position, for example, crumpled on his side, or is being moved by other EMS personnel, adapt the technique to the best of your ability to hold the head in a steady position in line with the spine. EMS systems have specific guidelines for when to use and when not to use spine immobilization. If this is the case in the system where you work, you should familiarize yourself with the local protocols and follow them. 1. When your patient is sitting up, position yourself just behind the patient and hold the patient's head by spreading your fingers over the sides of the head and placing your thumbs behind the ears. When your patient is supine, kneel behind the patient and spread your fingers and thumbs around the sides of the patient's head to hold it steady. The look test. At this point, experienced providers often get a feeling about the patient's condition. This feeling comes from environmental observations as well as from the brief but valuable information obtained by that first look at the patient as you approach. Some call this the look test. You will develop more of this instinctual approach to assessment as you gain experience. The ventilation, perfusion, and shock understanding pathophysiology chapter explained many of the things listed next as clinical topics. This chapter will discuss how and why they play a part in your assessment. For now, we will tell you some of the things experienced EMTs use to identify patients who may be critical, such as patients who appear lifeless. Patients who appear to be lifeless, who have no movement or apparent evidence of breathing, or have only gasping breathing, will be resuscitated by beginning CPR compressions and preparing your defibrillator as soon as possible if they are found to be pulseless. Patients who have an obvious altered mental status. An altered mental status can indicate many underlying conditions, from hypoxia to shock, to diabetes, to overdose, to seizure. During the primary assessment, your concern is not the cause of the altered mental status, it is the impact it will have on your patient and your assessment and care decisions. In this case, your primary assessment will be more aggressive because of a higher potential for life-threatening problems, including vomitus or secretions in the airway and the need for ventilation. Your subsequent assessments will likely be done more quickly to expedite transport. Patients who appear unusually anxious and those who appear pale and sweaty. These signs are indicators of possible shock. Recognizing these signs at the earliest possible moment will help you to identify this potentially serious condition early. In this case, recognizing anxiety, pallor, and sweatiness early will prompt you to look for other signs of shock as you complete your primary assessment, including observation of rapid pulse and respiratory rates. Identification of shock will help you make the decision to classify the patient as unstable or potentially unstable and expedite your assessment and care. Recognizing potential shock early in the call will help you perform appropriate assessments later. In cases of suspected trauma, you will match this information with the mechanism of injury, the patient's complaint, and assessment findings. In the medical patient, identifying shock may help you identify a body system to examine later. For example, the gastrointestinal tract for indications of GI bleeding, or the cardiac system for signs and symptoms of a heart attack. Obvious trauma to the head, chest, abdomen, or pelvis. Experienced EMTs identify serious trauma to these areas as injuries that can cause airway problems, profound shock, or death. Head injuries are serious because the brain is housed within the skull. Also because the head bleeds a lot when injured. The airway may require significant attention and care. The integrity of the chest is vital for breathing. When the chest is injured, normally adequate breathing may be disrupted by rib injury, collapsed lungs, and bleeding from the major blood vessels within the mediastinum. The abdomen not only contains a rich blood supply, but it also contains many organs that may be injured during trauma. Injury to the pelvis can cause severe and even fatal bleeding. Specific positions indicate distress. A tripod position indicates significant breathing difficulty, whereas Levine's sign indicates significant chest pain or discomfort. See figure 12.3 and 12.4 for the tripod position in 12.3 and Levine's sign in figure 12.4. Levine's sign indicates significant chest pain or discomfort. Seeing either of these signs tells two things. The level of the chest pain, of the chest discomfort or respiratory distress is severe, and the patient's complaints, cardiac and respiratory, are among the most serious medical complaints, indicating a high priority. The clinical clues just listed are not all-inclusive. There are many indications, some very subtle, that something is wrong with the patient. Something as seemingly simple as a statement that the patient isn't himself may indicate a serious problem. You should also remember that these signs are only part of the information you will gather. You will find unstable patients who present with none of these signs and patients with very minor complaints who look serious. Most important, remember that the presence of any of these signs usually indicates a serious patient, but absence of these signs does not guarantee the patient is stable. The chief complaint. The chief complaint is the reason the EMS was called, usually in the patient's own words. It may be as specific as abdominal pain, or as vague as not feeling good. In any case, it is the patient's description of why you were called. You form a general impression by looking, listening, and smelling. You look for the patient's age and sex, which are usually easy to determine once the patient is in sight. You look at the patient's position to see if it indicates an injury, pain, or difficulty in breathing. You listen for sounds such as moaning, snoring, gurgling, respirations. You sniff the air to detect any smells such as hazardous fumes, urine, feces, vomitus, or decay. Something that is more difficult to describe than your direct observations, but just as important, is the feeling or sense you get when you arrive at the scene or encounter the patient. You may become anxious when you see a patient who exhibits no outward signs of illness or injury, yet just doesn't look right to you. Or you may feel reassured when you are dispatched to a sick baby, but see that the infant is alert and smiling. After you gain some practice assessing and managing patients, you may develop a sixth sense that clues you into the severity of a patient's condition. This is part of what is called clinical judgment, or judgment based on experience in observing and treating patients. Some people find it easier than others to cultivate this ability, but even those who have excellent clinical judgment do not depend on it alone. A systematic approach to finding threats to life is the best way to make sure they are not missed. Figure 12.3. In cases of severe difficulty breathing, patients may assume the tripod position, sitting upright, leaning forward, and supporting themselves with arms locked in front of them. Figure 12.4. The classic sign of chest pain is Levine's sign, a clenched fist over the chest.